And the first thing we have to do is just kind of do a little bit of a review of, what is the definition of shock? What does our heart do? What does our cardiovascular system do to help maintain homeostasis? And review a couple of the little definitions that are going to be referenced in this particular lecture. So what is the definition of shock? What's happening when a body goes into shock? What? Right, there's a shutdown of the cardiovascular system, the cardiac or the pulmonary system. And what's happening with shock is that there's a drop in the amount of oxygenated blood that gets to the tissues. So we have basically in shock tissue perfusion that is inadequate to deliver nutrients and oxygen to the tissues and to the organs and the cellular function. And then our body will go into some compensatory mechanisms to return our bodies to homeostasis. So if we have an intact cardiovascular system, if our heart's pumping properly, all the stuff that we've talked about, the cardiovascular system is supposed to deliver oxygen and nutrients to the cells, right? Remove the waste products and regulate the blood volume. Make sure that we have adequate blood volume and adequate pressure so that all that good oxygenated blood is getting to the tissues and the waste materials are being carried away. And so if we've got good cardiac output, which is what? What's the definition? Heart rate times stroke volume, but what does it actually mean? It's the amount of blood being ejected by the left ventricle in 1 minute. So if we have good cardiac output and we have good systemic vascular resistance, which is what? Like the pressure, the blood pressure. So if we have good vasoconstriction so that it maintains an adequate blood pressure and good cardiac output, we're going to get good perfusion to our tissues. If that fails, then our body has to compensate to bring us back to homeostasis. So one of the compensatory mechanisms is the catecholamine fight or flight response. We have baroreceptors in the aortic arch, the carotid arteries, and they sense a drop in mean arterial pressure. And what is mean arterial pressure, you say? Is anybody going to say that? No. Pam, what is mean arterial? Okay. Mean arterial pressure, and I'm not going to ask you to calculate that on an exam, you hear that very carefully on my recording, is 2 times the diastolic, diastolic, plus the systolic, divided by 3. That's how, and mean arterial pressure just basically is a reflection of how well our blood pressure, how good our blood pressure is, and how well our tissues are perfusing. And what our body wants is our mean arterial pressure to be greater than 60. And when the mean arterial pressure drops, meaning our blood pressure has dropped, then those baroreceptors in the carotid arteries and the aortic arch will kick in the catecholamine fight or flight syndrome. So let's look at a couple of blood pressures that you might see and kind of do the math and see if we have a good mean arterial pressure or a bad one. If we have the patient that has the textbook blood pressure of 120/80, what would be our mean arterial pressure based on 2 times the diastolic plus the systolic divided by 3? So 2 times the diastolic is 160 plus the systolic 120. So we have 280 divided by 3, and that's what? Like around 90 something? Right. So we got a good mean arterial pressure. Now that same patient goes down to 80/40. What's the mean arterial pressure now? 2 times the diastolic is 80, plus 1 time the systolic is 80, 160 divided by 3, and that gives us 50 something, right? So we got a problem. So when that mean arterial pressure happens, we've got the catecholamine fight or flight response. The sympathetic nervous system kicks in. And what does the sympathetic nervous system do to our vital signs? Raises our heart rate, right? Raises our blood pressure by causing vasoconstriction. And what does it do to our GI motility? Slows it down. Because in a catecholamine fight or flight response, when we're being chased out of the woods by the bear, we don't need to digest the burger we just ate. We need to get out of and we need to outrun the bear. Or we need to outrun the person that we're with. Didn't take you as long to get that one as some groups. So we have a fast heart rate. So that's the first thing that our body's going to do when it goes into shock, is heart rate's going to increase. Because if the heart rate increases, it's going to get more oxygenated blood to the tissues. Because that's where the body is just saying, hey, I need more oxygen. So the first thing we're going to do is get a faster heart rate. Then what's going to happen, another way that we're going to raise that mean arterial pressure, is that the kidneys that are now not getting enough perfusion, they sense that drop in perfusion, and they kick in the renin-angiotensin-aldosterone syndrome. And basically what that does is it causes us to retain sodium and retain water, and that boosts our circulating blood volume. So as a compensatory mechanism, what you'll see in certain stages that we're going to talk about in a minute is that the urinary output is going to drop. And that's going to be an indication that our compensatory mechanisms are working. Because it means that the body is holding on to fluid, not diuresing, so that it increases the circulating blood volume and bumps up the blood pressure. And that improves your mean arterial pressure. And another compensatory mechanism that's going to reflect in some of the signs and symptoms we'll be talking about is our body is going to release glucocorticoids. Why does it do that? We need the energy. The cells need the energy because they're not getting the oxygen and the nutrients that they need. So the body says, oops, not getting enough oxygen and nutrients to the cells. I'm going to pump out some glucocorticoids, and that's going to help to improve nutrition. And it's going to raise the circulating blood sugar. So that's just kind of a little bit of a summary of what's happening. There's a lot of different things that happen in the body, but those are the major things that we see when the body goes into shock to get us back to homeostasis. And we have three phases. We have 4 phases of shock. The book says 3, and that's a very new way of approaching the phases of shock. I am teaching you the 4 phases, traditional 4 phases of shock, and what they're called, because that's probably what's going to show up on an NCLEX question. So what's in Pellico is a very new way of approaching the stages, and so it's there in your reading, and I'm going to address that. But what I really want you to focus on is the fact that you probably get tested on the NCLEX on 4 separate phases and what they're called, because obviously the questions have been written for a while. They haven't revised the NCLEX in a couple of years, so chances are the old descriptors are going to be on your exams, and the old descriptors will be on my exam. Just saying. So the phases are what the patient is going to go through as they progress through those stages of shock, and each stage is going to have certain signs and symptoms that are going to be specific for those stages. Now, that being said, it does not mean that there's going to be a line that says, okay, now we're on stage 1 and bada-boop, now I'm in 2. It's flows, it's an evolving kind of thing, and then depending on how the patient responds to our interventions, they can go back and forth sometimes between stages of shock as they get better and then they deteriorate and all that. So it's a fluid kind of process. But what's happening and the changes that are happening in the body and in the signs and symptoms that you're going to see are going to go in very predictable fashion. So the first phase is what we call initial or early. What Pellico does is combine that with the second phase, which is compensated and non-progressive, and calls that pre-shock or compensated shock. So this slide kind of talks about the different terminologies that Pellico uses, but if that left-hand column is really what you'll probably encounter on an NCLEX question when they're describing the various phases. So phase 1 is going to be the initial stage. You may hear it referred to as early or reversible. And it's because it can be reversed with minimum morbidity or mortality. Patients that are just entering that initial stage of shock, if you can correct whatever the underlying problem is, then they're going to go back to their baseline and back to homeostasis. And so usually in that initial stage, the only thing you're probably going to see is a rise in the heart rate. So stage 1. Stage 2 is what they call, referred to as either compensatory, because it says the compensatory mechanisms are working, or the non-progressive, which means that it's not progressing into a worse stage. So this is when, again, the compensatory mechanisms kick in, and you're going to start seeing an increase in some of those symptoms that are reflecting those compensatory mechanisms. So cardiac symptoms, we're going to see tachycardia. We're going to see somewhat of a decrease in the effectiveness of this. We're not really get back to homeostasis with this compensatory stage. So there's going to be a drop in perfusion in the periphery. We may see some cold, clammy skin and decreased capillary refill in this stage. And as the body detects that maybe this increased heart rate isn't really being as effective as I'd hoped, then the respiratory rate is going to increase. Because as the oxygen levels drop and the CO2 levels rise, the body wants to blow off that CO2. And the best way to do that is to increase the respiratory rate so that you are hyperventilating, basically. And you are going to be in what acid-base state? Respiratory alkalosis. So in the initial stage, patients trying to blow off CO2, they go into respiratory alkalosis as they try to compensate for the fact that oxygen levels are falling. The renal effects in this stage, this is when you have the compensatory mechanism that causes a decrease in urinary output. So in this compensatory stage, the drop in urinary output is not because the kidneys failed. It's not a bad thing. It's an indication that things are working to improve the situation. Later on, when we get to stage 4 and we have a drop in urinary output, that means the kidneys have shut down. But here, we're compensating. It's a good sign. We may start to get a little bit of restlessness, anxiety, as the amount of oxygen going to the brain starts to drop. And we're going to see a drop, a slowing down of the GI peristalsis. Again, that fight or flight. We'll see a little uptick in the blood sugar levels because of that glucocorticoid release, again, a compensatory mechanism. And then as we tip down and get towards that non-compensatory phase, what happens in this phase is that the cells are going to shift to anaerobic metabolism. Remember that from A and P? Yep. So what happens is the Krebs cycle. You had to remember that, right? Oh, I hated that. But what happens is because the cells aren't getting enough oxygen, they switch to anaerobic metabolism. That pumps up the lactic acid levels as a byproduct of that anaerobic metabolism, and that causes metabolic acidosis. Another reason why your respiratory rate is going to increase, because the body's trying to compensate for that metabolic acidosis. So pulse is going to go up, blood pressure is going to start to go down, urinary output's going to decrease, maybe a little bit of CNS because of lack of oxygen, and slower GI motility. Yes?
I don't know how, so when patients are on hospice and they show all of those signs before they die, is that the same, are they going into shock
It's the body, the cells are being deprived of oxygen, their cardiac output is dropping as they're in the terminal stages. Cells begin to die, and when cells begin to die, you have that lactic acid release, you have potassium release from cell destruction. So all of that is part of that whole process in that terminal patient. It's just that we're not going to do anything about it in that patient on hospice because that's the natural progress of what we anticipated they're going to be. So that's shock stage 1, just some tachycardia. Stage 2, we're going to have all of these, more tachycardia, lower blood pressure, the decrease in renal function because of the compensatory mechanism, a little bit of confusion and anxiety, and slower GI. Now, if the body does not return to homeostasis, they're going to deteriorate down into the 3rd stage, which will be referred to as progressive or non-compensatory. This means that the compensatory mechanisms have kind of pooped out, they're not effective anymore, and the patient is having significant deterioration of their status. So they cannot tolerate this level for very long. You've got to reverse the shock and get them back and give them the support that they need to get them back to homeostasis. And one of the ways that we see with patients with going through these phases of shock, a lot is going to depend on things like age and comorbidities and how severe the underlying problem is. All those things are going to affect the body's ability to compensate and whether or not we're able to support that patient until the body kind of picks up and is able to compensate on its own. So now we're in stage 3. Now our heart rate is very fast. Our blood pressure is very low. We have very weak peripheral pulses, very cold, clammy skin. Now we're starting to see the signs and symptoms of renal failure as the BUN and the creatinine start to kick up, because now it's not a compensatory mechanism that reduces the amount of urinary output. Now we've got renal problems. Now we've got renal damage because of that lack of perfusion. Metabolically, we're going to see elevations in lactic acid levels, ammonia levels. And if we have elevated ammonia, bili, liver enzymes, what does that indicate? Liver failure. Higher levels of glucose as other organs are failing. Pancreas can start to fail. Respirations become a lot more rapid and shallow. This is when patients with particular types of, when patients in, say, a cardiogenic shock goes into pulmonary edema. This is when a patient in septic shock is going to go into ARDS, because their respiratory status is deteriorating significantly. And they start becoming a lot more lethargic. So their CNS starts to get more sluggish. Okay, let me pause this, because I just... So stage 3. And then I will recap stage 4. So ignore the previous stuff that I said about stage 4. Stage 3. So cardiac, increased heart rate, decreased blood pressure, increased risk for MI and dysrhythmias, weak thready pulses. We will start having pooling of blood in the extremities because of the poor venous return, and we will have developing of DIC in some types of shock. We're going to again start to see a decrease in urinary output, not due to compensation, but because of renal insufficiency. Increased lactic acid levels, increased metabolic acidosis, and a deterioration in mental status. And this stage, again, as I said before, cannot be tolerated for very long with that patient. We need to correct and reverse. Or they will go back into Stage 4, irreversible or refractory, or what is referred to in the Pellico book as end organ damage. Patient cannot survive this stage. Once they get to this point, there's nothing more that we can do for them. This is when they can go into cardiac arrest, complete renal failure, a total absence of bowel sounds, and they become unresponsive. So did I totally confuse you, or are we all set on that one? So we just, yes. What's that? Right, the lethargy, they become unresponsive and sluggish mentally, that's stage 4. Yeah, they become comatose. It's just a change in the mental status, a further deterioration of mental status, but they don't, in most cases, become comatose or totally unresponsive. Again, it's very fluid as patients go through these stages. So it's not like you've got one line here, they're in the compensatory or non-compensatory, and then they're into the refractory or irreversible. It ebbs and flows, and it's going to go, it can go very quickly with some patients in the space of an hour, and in some patients it can take days to go through this, again, depending on how well they can compensate. Yes, Joel?
So earlier on when you said very high increased pulse, very low blood pressure, you were describing stage?
Yes, yes, the very low blood pressure, very high, the high thready pulse is going to be that stage 4, yes. Yeah. Pulmonary for stage 3, a more rapid respiratory rate, again, trying to compensate for that metabolic acidosis.
So we have weak thready pulse and full time scan for both stage 3.
Yeah.
It just gets worse.
It just gets worse. Yeah. Okay, so those are the 4 stages. And now we're going to talk about the classifications, the causes of shock. So there's a lot of things that can cause a patient to go into shock, and they're all going to go through these stages that we just talked about. Some of the signs and symptoms for some types of shock might be slightly different, and we'll be talking, I'll be kind of highlighting those differences. So the first type of shock that a patient can have is hypovolemic. So what's happening in hypovolemic shock? Why is the patient going into shock? We're bleeding out. We're losing intravascular volume. So with hypovolemic shock, we have a decrease in our intravascular, our circulating blood volume. And because of that decrease, the tissues are not getting enough oxygen. Because in all types of shock, the underlying problem that causes the whole process is the fact that the tissues aren't getting enough oxygen. In this case, it's because there's not enough blood circulating to carry the oxygen to the tissues. So what are some causes of hypovolemic shock? Hemorrhaging, either external or internal. What else? Dehydration. And what else? Diarrhea and vomiting. And massive fluid shifts within the body. So if your patient has massive ascites, and it's a sudden shift of fluid into the peritoneum, then they can become hypovolemic and show signs of hypovolemic shock. So our treatment for hypovolemic shock is to correct whatever the underlying problem is and replace the fluids. So we need to restore intravascular volume and fix whatever is causing the problem. So some of the ways that we, come on, go on to the next slide. There we go. Fluid replacement. We are going to give crystalloids, which are volume expanders. So normal saline, and frequently lactated ringers or Ringer's lactate. And the reason that we give Ringer's lactate is because it acts as a buffer for the lactic acidosis that the patient is experiencing as they deteriorate through these stages. So that metabolic acidosis occurs, the lactic acidosis, because of anaerobic metabolism. Ringer's lactate buffers that and tries to bring that pH back up to where it should be. Yes?
But wouldn't that also complicate medicines and everything, because there's hardly anything you can give?
Well, and they're going to have a triple lumen catheter, and they're going to be, as long as you can't really piggyback a lot of meds into lactated ringers, but you can, if you've got a triple lumen, you can administer the meds through the other ports. We're going to give colloids. They're IV fluids that will help to increase the pressure and expand the blood volume. So albumin, dextran, and hetastarch are all things that we might give that patient to expand their blood volume. Or we can give them blood products. So if they're having a hemorrhagic stroke that's causing their hypovolemic shock, hemorrhagic loss for their hypovolemia, they're going to get whole blood, packed red blood cells in order to better carry the oxygen to the tissues. Or they're going to get FFP and platelets to help to clot and prevent the hemorrhaging because of a clotting issue. Yes?
If they're bleeding out, how fast do you infuse blood?
Very fast. Very fast. You can put, when we talk about septic shock, 500 milliliters an hour. With burns, when we talk about burns in a few weeks, we're going to do some math and show that the patient's going to get close to 1,000 milliliters an hour, a 1 liter bag every hour to replace the fluid that they're losing. In which case, you're probably going to need to have a pressure bag to help, to maximize that ability to pump that in. So that's hypovolemic, a drop in circulating blood volume, which causes a drop in perfusion to the tissues because there's not enough oxygenated blood to get to the tissues. And then we're going to talk about cardiogenic shock. And cardiogenic shock means that the tissues are not getting enough oxygenated blood because the pump is failing. And it's something that's actually wrong with the pump as opposed to an external problem that causes the pump to fail. It is probably the most lethal form of shock. Patients that go into cardiogenic shock have an 80% or more mortality rate. And so what do you think some of the causes might be of cardiogenic shock? One of the most common ones. Heart failure, severe congestive heart failure, or an MI that damages a large part of the ventricles. Patients can develop cardiogenic shock because of pulmonary embolism. Why would you think that might cause cardiogenic shock? Right, they're not getting oxygenated blood, and the heart has to pump so hard to try to get blood to the lungs that it can fail, and then it sets off this whole cascade of cardiogenic shock. Now, clinically specific signs and symptoms that you're going to see with cardiogenic that you're probably not going to see with other types of shock are going to be things like JVD and lung crackles. Why? The heart's failing. So when you think of signs and symptoms of cardiogenic shock, think of signs and symptoms of somebody in really bad congestive heart failure and all the signs that go along with that. Because blood is not getting pumped adequately by the pump. It's backing up into the lungs and into the periphery. So our treatment for cardiogenic shock is we need to fix whatever the underlying cause is. Some patients that come in with a severe MI and are starting to go into cardiogenic shock go right to the cath lab or go right to have a cabbage. Because what we have to do is we have to fix whatever the perfusion problem is for the heart so that it can pump properly. If it's because of valvular issues, weak valves that have caused the failure of the heart, then we have to go in surgically and fix the valves. A lot of the treatments for cardiogenic shock, the basic treatments, are going to be very similar to acute CHF. Diuretics, nitrates, afterload reducers, preload reducers. And then some of the critical care medications that we're going to use for cardiogenic shock, because we have to improve our myocardial contractility. We have to make it easier for the heart to pump. We have to strengthen the heart because it's weak. The heart is failing as a pump, and that's why we're in shock. We need to help to promote vasoconstriction because we need to bring that blood pressure back up. And we have to enhance the perfusion of the myocardium, since one of the major causes of cardiogenic shock is an MI, a severely damaged left ventricle, for instance. So we need to improve that perfusion. So let's talk about dobutamine first. Dobutamine is a positive inotrope, not to be confused with dopamine, which is a vasopressor, a vasoconstrictor. A lot of people get that confused. And what dobutamine does, just like DIG, strengthens myocardial contractility. But dobutamine will also relax the peripheral blood vessels, which can do what to your blood pressure? Can drop your blood pressure. So here's Med 1 that we're giving that patient in cardiogenic shock. We're giving him dobutamine because his heart is really weak and we need to improve contractility to improve cardiac output. But because he's in shock, he has a low blood pressure. And we're giving him a med that can relax the peripheral blood vessels and drop the blood pressure. So now we got to give him something to help improve the blood pressure. So that's going to be our dopamine, because dopamine is going to improve vasoconstriction. So we're giving dobutamine to help the heart pump better. We're giving dopamine to constrict the blood vessels and maintain an adequate blood pressure, because if we don't have adequate blood pressure, the tissues can't perfuse. So we got two drugs kind of fighting against each other. That's why they have to be in the ICU, and that's why they have to be titrated, and why they're being hemodynamically monitored. Because we need to keep their intracardiac pressures stable, their central venous pressure stable, and we need to keep their blood pressure stable so that they're getting good perfusion, but we don't want that blood pressure too high, because what's that going to do to the workload of the heart? It's going to increase the workload of the heart on a heart that's already weak and can't pump effectively. And then in our patient with cardiogenic shock, most commonly caused by a severe MI, we have to give him nitrates to improve myocardial perfusion, because he's got a dying myocardium, and time is muscle, and we've got to get those, we got to improve that perfusion to the myocardium, so we're going to give him nitroprusside. What does that do to your blood pressure? Drops it. So yes, this patient has to be very, very closely monitored. So let's do some math. We have a dopamine drip to be started on your patient with hypovolemic shock. You have 400 milligrams in 250 mLs of D5W. The order is 5 micrograms per kilogram per minute. The patient's weight is 190. So the question is, what is your pump setting in milliliters per hour, and round to the 10th position? So what's the first conversion that you have to do? Pounds to kilograms. So how many kilograms is he? 86. Is that what everybody got? 86? Is that what I got? That's the important thing. Yes, I did. Because what's so embarrassing is when last semester when I put this slide up, I had totally done the math wrong. I don't know if it was on this one, but it was on or one of the other ones, but I was like, that's embarrassing. Okay, so now what do we have to do? We have to convert how many micrograms per minute to micrograms per hour, right? Because we have the pump has to be set at milliliters per hour. So we can do that conversion. So if we have 5 micrograms per minute, how many micrograms per hour is that? 5 times 60? 300. Okay, 300 micrograms per hour. But it's micrograms per kilogram per hour. So what is the total amount that we have to give per hour? How many micrograms per hour? We have to multiply kilograms times the micrograms per hour, right? And that gives us 25,800. Everybody get that? Okay, so 25,800 micrograms per hour. So that's our desired, right? What do we have? 400 milligrams in 250 mLs. So what conversion do we have to do now? We have to convert the milligrams to micrograms. So 400 milligrams equals how many micrograms? If we go from larger amounts into smaller amounts, we move the decimal point to the right. If we go from smaller to larger, we move it to the left. So we have to move the decimal point how many places to the right? 3. So that's 400,000 micrograms. So our desired is 25,800 micrograms per hour. Our have is 400,000 micrograms. And our volume is 250 mLs, right? So we can get rid of the micrograms, and that leaves us with milliliters per hour. Do the math, and what did you come up with? 25,800 divided by 400,000 times 250. 16.1, because you rounded it. What did you get? 16.12 something or other? Yeah. Everybody got that? That's the approach you have to take with these multi-step types of questions that you will probably see on my exam. Because you've got to do your conversions, and it's always good to do the conversions first and then plug it into whatever formula that you like to use. That way you don't forget to do the conversion and do the complete process. So I am going to pause this. Of nipride in 250 mLs of D5W. The order is 2.5 micrograms per kilogram per minute. The patient weighs 143 pounds. So what is your pump setting in milliliters per hour? So what's our first conversion? So pounds to kilograms. So what does he weigh in kilograms? 65. What else do we have to convert? Micrograms per minute to micrograms per hour. So how many micrograms per hour? So it's 150 micrograms per kilogram per hour. And what else do we need to convert? Milligrams to micrograms. So 100 milligrams is how many micrograms? 100,000 micrograms in 250 mLs of D5W. So now we need to find out for the patient how many, micrograms, how many micrograms per kilogram per hour. So how many micrograms per hour based on the number of kilograms? What are we going to do with that? So 65 times 150, right? So what does that give you? 9,750 micrograms per hour. That's our desired. What do we have? 100,000 micrograms. And what's our volume? 250. So we cancel out the micrograms, and we get what? 24.4 milliliters per hour. So did everybody see how we got that? Okay. Okay, the next type of shock that we're going to talk about is distributive shock. And there's 3 different types of distributive shock that we're going to talk about: neurogenic, septic, and anaphylactic. So in one type of distributive shock, we have a loss of sympathetic tone. So if we don't have good sympathetic tone, what happens to our blood vessels? They can't do what? Can't constrict, because it's the sympathetic nervous system that stimulates the blood vessels to constrict. So we have blood vessel dilation, we have pooling of blood in the venous and capillary beds, and we have increased permeability of those capillaries. And because of that, the mean arterial pressure drops. So some of the causes of distributive shock can be neurological changes that cause that loss of sympathetic tone, or the presence of chemicals that cause capillary permeability and loss of fluid out of those capillaries and pooling. So the first type that we're going to talk about, distributive shock, is septic shock. And the pathophysiology of septic shock is exactly what we talked about when we talked about ARDS, a systemic inflammatory response syndrome, SIRS. And what's happening when we talked about ARDS, remember we talked about a capillary leak, fluid leak into the alveoli, right? Well, SIRS also causes a systemic problem with capillary leak. So that's the chemical, in this case the bacteria or whatever the causative organism is, that causes the SIRS response, that damages the blood vessels and causes capillary leak. And they drop their blood pressure and their mean arterial pressure because fluid is leaking out of the intravascular space. There's two phases of shock that you will hear talked about. There is the hyperdynamic or warm shock. You may have heard it referred to as warm shock, or the hypodynamic, which is the cold shock. So when patients start to go into septic shock, because we have a systemic inflammatory situation going on here, early on, that patient is going to be pink and warm skin, flushed, because they've got an infection going on, inflammatory response. So they get flushed, they get warm. They're going to have bounding pulses in those early stages, because they haven't lost any of the capillary leak yet. And the body responds to this inflammatory response by increasing the heart rate, pumping the blood more rapidly, and because they haven't lost any blood volume, they have nice bounding pulses. And they have vasodilation. If we don't detect that they're going into hyperdynamic phase of septic shock, and they deteriorate further, then they go into that cold hypodynamic phase. This is when things start to drop out of the bucket and go down the tubes. The blood pressure drops, the cardiac output drops, we're losing fluid into the intravascular space, we're getting cold, clammy skin. So we've got the warm, pink skin in the hyperdynamic phase, the cold, clammy skin in the hypodynamic phase. This is when DIC and ARDS are going to happen, because the capillary leak has started, the patient's deteriorating, and they're going to start getting the leakage of fluid into the alveoli, and they're going to have DIC, which you learned about in OB, right? Where the blood pools and it clots. And we're going to talk specifically a little bit more about DIC in a second. What are some of the causes that can put a patient into septic shock? What kinds of things can happen? So massive infections. Patients that have gram-negative organisms like Pseudomonas and E. coli. So think of that patient with the UTI, with an E. coli UTI, going to be at risk for septic shock. Gram-positive infections like staph and strep can also lead to sepsis. And which types of patients do you think would be at a higher risk for developing these kinds of systemic infections and going into septic shock? Immunocompromised patients. So patients with malignancies or patients getting chemo, because they're immunocompromised. Patients with HIV, AIDS. Patients that have been on a lot of steroid types of treatments, hormonal treatments. Large septic decubiti. Christopher Reeve, prime example. That man probably had the best nursing care money could buy and still died of septic shock from an infected decubitus. It happens. Patients who are malnourished. So some of our elderly patients who get a little bit of a UTI, and because they're malnourished and they don't have the resources to help compensate for that, they become septic and they go into septic shock. Our treatment for septic shock is going to be whatever the organism that caused it. So normally what will happen is you'll give a broad spectrum antibiotic in the initial stage until they get the cultures back and they find out what's causing the sepsis, and then they can be more specific to that organism. Fluid resuscitation is going to be important because patients will lose a lot of intravascular fluid into the tissues, so you need to replace that circulating blood volume. And vasopressors, specifically Levofed, norepinephrine, is one of the most common vasopressors that you'll see in patients with sepsis. Because they're at a high risk for ARDS, they're going to be, most patients once they start going into septic shock are going to be in the ICU, and they're just hanging out there ready to get that patient intubated and intubate them, so they know that there's a very good chance they're going to go into ARDS, they're going to need to be intubated. Now, DIC is a very common complication of that patient in septic shock. Disseminated intravascular coagulation. And what's happening with DIC is you're having a paradoxical syndrome of first multiple thrombi developing, so thrombosis in the microcirculation. And then if that's not treated soon enough, they will go into hemorrhage. So it starts off with a lot of clotting in the periphery because of the pooling, and then they will go into hemorrhaging. And the video is going to tell you why that happens. So we have two phases of DIC. So if they're in phase 1, where they're having all this abnormal clotting, what do you think you're going to give them? Anticoagulants. If they get past that phase 1 and they get into the later stages of DIC where they're having abnormal bleeding, they're not clotting anymore, what do you think you're going to give them? You're going to give them FFP, you're going to give them clotting factors, plasma. So you have to treat whatever is happening to that patient. First the abnormal clotting, then the hemorrhaging. Not necessarily. No, the patients do survive DIC. Diagnostically, if the patient's in DIC, if they're hemorrhaging, if they're in that hemorrhaging stage, that's stage 2, they're going to have elevated PT, PTT, so all their bleeding, their clotting studies are going to be prolonged. They're going to have increased fibrin degradation products, increased D-dimer. So that D-dimer that we talked about in respiratory, as one of the parts of the diagnostics, it will also show up elevated in DIC, which is why it's not going to be definitive for the pulmonary embolism. And they're going to show other signs of bleeding, things like petechiae, bruising, oozing of blood at IV sites, injection sites. They will cough off blood, which is known as hemoptysis. They can have mental status changes because of bleeding in the brain. So it's a pretty severe, I mean, patients go into DIC, it is a very high mortality rate, but that patient can get them out of it. And again, with any type of shock, it always is dependent on how severe the underlying cause is and how much reserves that particular patient has in terms of their ability to compensate. If they're elderly, if they're immunocompromised, if they have a huge issue with the underlying cause, they don't have a lot of strength to compensate, then the situation is going to be much more severe.